Good morning. Thank you for having me, Anna. It's always a pleasure to be here at the Women in MPN conference, and I'm going to talk to you more just sort of generally about the patient journey and give you sort of a sense of how it looks from both directions. These are my conflicts. And, we have as a physician, some administrator who decides that we're going to have a 15-minute visit. Like that's what our follow-up is going to be. So when we're a physician, we're there thinking that we have to communicate, hear what the patient has to say, and come up with a plan in 15 minutes. And so we have a particular perspective on those 15 minutes because we have a short period of time to do what we need to do. But the patient also has a perspective, and also these perspectives are often different. So the physician is thinking, are the blood counts controlled? If they're on a drug, have the clinical trial endpoints been met? Has there been a decrease in the spleen size, a decrease in the total symptom score, any new symptoms, any new cardiovascular events, any new medical problems, any new blood clots? And is the patient taking their medicine like they tell me they are? So those are the things that I'm thinking about. But the patient perspective is often very different. The patient's topmost, concern might be, I'm worried I'm going to die early, and I'm really anxious about this. They're also saying, why am I so tired? I'm so fatigued that I can't do all the things I want to do when I want to do them. I have a mental fog and I have trouble concentrating. I'm not as good at my job, or I'm not as good at my social interactions because I have this fog in my brain. I think my symptoms are from the medication. So I stopped it because I don't like the way you prescribed it. And what supplements or what can I do through my diet or exercise or supplements? What can I do to change my outcome? So the two perspectives at the second that we meet each other in the office might be entirely different. And patients don't feel well much of the time, and they want those problems solved. And it's quite true that clinical trial endpoints just don't align with patient expectations about their treatment. Like they're not caring whether they have exactly a 35% reduction in their spleen size, and they're not caring about a little score change in their total symptom score. That's not what they're really thinking about. They're thinking, how can I prevent myself from dying early from this disease? I really want to have a good outcome. And some patients don't even recognize that they have symptoms. So I might be trying to put them on a clinical trial, but they've felt poorly for so long that when they're given a questionnaire to fill out, it's their normal habitus. So they can't actually recognize that they have symptoms until they get better. And then when they get better, they're like, oh, I feel better. But they couldn't record any unpleasant symptoms before then. Anxiety about their disease is sometimes supported by what they read on the internet. So they may read about other patients' experience and translate that to themselves. And there are good lessons in real world data that they reveal in most trials. The symptom burden might not correlate at all with the severity of the disease. So, patients may have a lot of mutations and look like a high-risk patient, but they feel pretty well, or a patient has a very small allele burden of JAK2 positive disease, and they have a lot of symptoms and feel poorly. So it doesn't necessarily correlate at all. And how do we, as a physician, support these patients in their concerns and manage the disease and side effects of treatment in the 15-minute visit? And it's a challenge on both sides. The thing that most patients complain about the most is fatigue and brain fog. And I wish there was a great pill out there that treated fatigue. Probably if that was there, we should put it in the water and we would all feel a lot better. But it's a problem because it's a symptom which is ubiquitous basically to the MPN patient. and we don't have a great treatment for it. So there are, lots of studies sort of documenting that fatigue is a big problem. There's a Netherlands study where fatigue was the most common symptom, and almost half of patients reported that their MPN and fatigue from their MPN affected their ability to work. And the reveal in most studies for looking at all three myeloproliferative diseases, there was a high symptom burden. But fatigue was the most common symptom, and the highest severity, with 80% of patients reporting that that was a rate-limiting symptom for them. And there's a study looking at the impact of MPNs on patients' employment status and work productivity in the United States, and this is a cross-sectional study. And 50% of patients reported a change in their employment situation because of their diagnosis. 30% of patients left a job. 24.8% of patients went on medical disability leave, and 21.8% of patients had reductions in work hours for at least 3 months. So this is impressive, right? This is a problem which really affects MPN patients and their ability to function in their day-to-day life. And a major goal should be for all of us who treat these patients is to try and alleviate these fears and alleviate this symptom. And how can we maximize a patient's functional status while they have this disease? We talk a lot about individual symptoms, but what we really want to know is, are you functioning in your work? Are you functioning in your social life? Are you able to go to the gym? Are you able to do the things that you want to do? Or is your life terribly limited by the disease that you have? And that's what we really need to know and figure out how to solve for our patients. What's the best way to combat fatigue? It's probably treating the underlying disease and managing the side effects of therapy. But there's a lot of interest amongst patients for integrative therapy, diet, exercise, supplements, like which of these things might work. And ASCO actually has guidelines for the treatment of cancer fatigue. And what can we take away from this guideline, and is there useful information there? As an aside, I have a sister who has stage 4 lung cancer with terrible fatigue as her main symptom. I've looked at these guidelines and tried to figure out, can I help my sister, with any of these things? And, it's actually, we're going to talk about it a little bit, but there isn't a lot out there that really treats cancer fatigue. So what kind of tools do we have in the box? And here are the treatments that we have for myeloproliferative diseases, which you're all very familiar with. And I'm just going to speak about generally. Polycythemia, we have the old-fashioned phlebotomy, Hydroxyurea, Interferon, ruxolitinib. And thankfully, we finally have some clinical trials out there looking at new drugs in polycythemia vera. For essential thrombocythemia, same collection of tools. We have Hydroxyurea, we have anagrelide, we have interferon, we have ruxolitinib. Some of these are harder or easier to get through insurance approval. And clinical trials are kind of few and far between. We have a couple of, but not as many as we would like in this disease. And myelofibrosis, again, we have the JAK2 inhibitors, we have 4 of them approved, but we all know that they're not the cure for the disease. So there are clinical trials out there, and clinical trials have already come through the wave and swept through and have been pulled back again. So, we have drugs out there, but what's really going to be the winner, we don't really know. And sadly, in the last week, we lost, Incyte pulled the BET inhibitor, which was a drug that, we had been using in patients. And I actually had some patients that were doing really well. So now what are we going to do now that this clinical trial has been terminated? So, these are the tools that we've got in the box. And, as mentioned in a previous talk, for a young and active patient, coming in at a reasonable interval for phlebotomy is extremely difficult. And a lot of people find the procedure to be unpleasant. And lastly, it's not free. The cost of coming in and doing it, the cost for the patient, is time away from their job. And the cost for the institution is you got to get a nurse, you got to get a chair, you have to have a person who's experienced in doing a phlebotomy. It takes time. They may not find a vein. There can be, an unpleasant kind of interaction. So this is not something that costs zero. It's something that the insurance pays actually a lot for, and it's an experience that you are getting that may or may not be an optimal experience. So phlebotomy is the first line treatment, but it may require more frequent visits to see your doctor. Your blood counts can become unstable between your visits. So you have an increase in symptoms, and then you get phlebotomy, you feel a little better, then your counts go up again and you don't feel that good again. And patients don't really like it. I mean, honestly, there are some that are okay with it, but it's like medieval, right? We're going medieval on you, and people don't necessarily think that's a great thing. And it does result in iron deficiency, which is a whole problem in itself. And it's hard to replete iron in these patients. And so clinical trial results of the new drugs out there for polycythemia are pretty exciting, looking at rusfertide and potential, approval of this, which is a way of avoiding phlebotomy and maintaining your iron stores. Like, this is an exciting potential new development. The other thing we have are these big old pills, hydroxyurea. Here's a picture of these gorgeous things, and they cost about $6.75 each. So it depends how many pills you're taking per day, but the good thing about it is it's very economic. But the bad thing about it, it's a big old pill that you got to take, and you can't cut these in pieces very well. If you've ever tried to cut hydroxyurea, it doesn't really work that well. So you can, but that's another problematic thing to be involved in. So this is something that is when we don't want to do phlebotomy, this is often the next sort of tier. And it brings the blood counts down quickly, which is really wonderful, particularly if you're trying to prepare someone for an operation or something like that. Over time, the phlebotomy requirement can be decreased, but it can be challenging to control just one aspect of your blood count and not affect the others, because it's kind of an all or nothing type of treatment. Your white count can go down, your platelet count can go down while you're trying to control your hematocrit. Resistance can develop over time, requiring dose escalation, and it looks like it can negatively affect quality of life scores in some patients with lower TSS or higher TSS. Mouth ulcers or skin ulcers may require that the drug be stopped. And some patients have GI distress, on these drugs, which really limit your ability to treat them optimally. There's also a possible association with the development of secondary malignancies. This is controversial. Skin cancers are probably the strongest evidence, but there is evidence that it doesn't really make a huge difference in the incidence of that. So, but it's out there as a potential toxicity. But once we move on to the next level of therapy, we're talking about the next level of financial toxicity. So Bezremi is actually pretty expensive. It's $15K a month. And depending on what your insurance is, you may have a relatively high copay, or you may have almost no copay, but it's completely mysterious when we prescribe the drug. The doctor has no idea what your copay is going to be. So it's a complete mystery to us. We prescribe the drug, we cross our fingers, we hope that you have no copay, but we're not going to know until it goes through the entire insurance procedure what the cost is going to be to you. So we recommend it, we give you the data, we show you overall survival benefit. But always in the back of our mind is this discomfort because we don't really know how much it's going to cost you. And then if we see bad news, like it's going to be $1,000 per month for copay, and we've sold this drug to a patient like we feel uncomfortable, we're in kind of a bad position. But this is the situation with Bezremi. There's a lot of emphasis from the company on a very quick escalation of doses. Generally, I don't see that that's necessary. You're also battling nurses from the company who are calling the patients and telling them that they need to increase their dose, and that might not be the case. So there's a lot of physician discomfort sometimes when we prescribe these medicines, and sort of an unknown variable for the patient. Ropeg, there are a number of trials really looking at this drug. There is a survival benefit after a year of treatment, which really suggests there's disease modification in the bone marrow. We're going to have to wait and see what long-term follow-up looks like. It is an injectable medication, and this can be difficult for some patients. There needs to be nurse teaching, and for some patients, ongoing support in giving themselves an injection. It can cause mood disorders. We've used at Cornell interferon in various forms over 25, 30 years. And when we look at our data, there are patients who have had suicides on these drugs. So you have to be very vigilant in following people's moods and feelings. There's an increase in the risk of autoimmune diseases, so there needs to be monitoring of liver and kidney function and thyroid function, and there has to be an intermittent physical exam. It can't be all done by video visit, 100%. And I have had in older patients some malignant level hypertension, which I never saw with Pegasus. So I don't know if this is going to be a long-term problem with this drug or not, but it's something I have a question mark about, and it's in the back of my mind. There's a lot of potential side effects, other than what I've discussed, like flu-like syndrome, joint and muscle pain. Fatigue could potentially become worse on this drug. And, there may be a need to hold the drug or to give NSAID or Tylenol treatment to make people feel a little bit better on a regular basis. In patients who have itching, it actually might make it worse, and you have to add antihistamines or JAK inhibitors to their regimen in order to control this particular symptom. It may be immunosuppressive. We don't think so. We think it's actually a positive for the immune system. But you have to always warn patients about infections and make a decision when they call you as to whether this needs further workup or antibiotic treatment. Patients need regular eye exams because there is a potential for retinopathy on these drugs. And patients can have an allergic reaction to the injection of Bezremi, which requires emergency care, including steroids, Benadryl, and maybe epinephrine. So it's always important that you talk about these side effects with patients, but these are things that can happen when you start patients on Bezremi. So let's go to the next level. Let's say that interferon's not working, or you need to add something for another symptom, like a JAK2 inhibitor. Then we start going up, of course, in the price tag. So ruxolitinib, last time I looked, was $17K per month. Every time I look, it seems to go up just a little bit. So I'm not really sure, where this ends up finally in the price point. Momelotinib and the other new JAK2 inhibitors, they range anywhere from $25K to $33K per month. And again, every single time that I prescribe one of these medicines, it's a mystery to me how much the copay is going to be for you. So, I am waiting for it to go through the entire insurance process to know whether or not it's going to be something that you can really afford. That always is uncomfortable for the doctor. And, for the patient, of course, uncomfortable too, because you're waiting to hear what the price tag is going to be for you. Ruxolitinib, the benefits of these drugs have been outlined in the following trials, and other clinicians have gone over this with you, I'm sure, and will go over it with you again and again. So there's very good data. The side effect profile, there's cytopenias, mainly anemia, but you can develop neutropenia and thrombocytopenia. And there is the risk in patients who've not required transfusions previously that once you start them on this drug, that they may require transfusions, at least initially when the drug is first started. These drugs are immunosuppressive, so there's a documented increase in zoster infections, but there's also increases in urinary tract infections, and there are case reports of reactivation of tuberculosis, grade 3 infections, hepatitis infections. There are case reports of cryptococcus, PCP, these are the kinds of infections that you get when you have HIV, toxoplasmosis, something called PML, something called JC virus, and Legionella pneumonia, which is a potentially fatal problem. One of the challenges I have as a physician is if a person develops a fever or is sick with something, to call me. I put them on the drug that might be responsible for them developing an infection. And what often happens is they go to a doc in the box somewhere, and they get a Z-Pack, and they're sent out, without proper, investigation of their infection. So it's really hard to get that message across, and it's really important. You can develop fatigue from both the drug and your underlying disease. Bruising is exacerbated on patients who are on ruxolitinib. So if you're on that drug and you're on aspirin, you might have a lot of bruising, and it's concerning, and you think it's related to your disease, or you want to discontinue the drug. There are patients who develop diarrhea that require antidiarrheal medications, and in rare cases, we need to hold the drug. And people are really disturbed by weight gain. So this drug can actually cause you to gain weight. And that's because it crosses the blood-brain barrier, and there's actually something in your midbrain which controls how hungry you feel. And this drug can interfere with that little pathway and make you feel more hungry. And you eat more. And that's a hard thing. Like if you're hungry, you want to eat. And it's really hard to change that habit of a lifetime habit. We call nutrition, we ask them to see the patients, and we try and put patients on exercise programs. But it's like patients who are on corticosteroids that you can gain weight, and that's very unpleasant. Some patients develop headaches, and they can be so bad that it requires a dose hold or discontinuation. So ruxolitinib in a lot of patients makes them feel better, but there are a number of side effects, and side effects that people really don't like the weight gain. Momelotinib, approved for myelofibrosis, again, good data for this trial. It's both a JAK2 and an ACVR1 inhibitor, which may protect against the side effect of anemia, which is really important and has made us pay a lot of attention to this drug and even consider switching people who are on ruxolitinib to momelotinib because it improves this symptom. But there are side effects. One of them is peripheral neuropathy, which is quite unpleasant, which is numbness or tingling in your toes or your fingers. It can interfere with your ability to button a shirt or to sew a button on a shirt or any small motor type of activity. And this may require dose modification and treatment with drugs that may make that symptom better, which are not cheap, and another drug that you're taking during the course of the day. And oftentimes I have to send them to neurology for a more comprehensive evaluation, because there's so many things that can cause peripheral neuropathy and how you actually treat this in the best way possible. The drug can also cause fatigue, immunosuppression, cytopenias, liver function abnormalities. It can make your itching worse. I tried to switch a patient from ruxolitinib who had controlled itching that had been really terrible to momelotinib. The itching came right back. I had to switch him back to ruxolitinib. So it might not be as good at symptom control as the sort of broader medication, which is Rux. And again, you can have headache or diarrhea. The JAK2 inhibitors share, all of the same sort of side effects. Pacritinib, again, like momelotinib, is been documented to be effective in multiple clinical trials. And in addition to being a JAK2 inhibitor, it's an ARAC1 and ACVR1 inhibitor. And the drug has been marketed to be targeted to patients who have a low platelet count. So patients who have a lower platelet count, this is really thought to be the best option for patients. But again, there are GI side effects. 50% of patients reported diarrhea. There can be the development of thrombocytopenia and anemia, even though there are these protective, pathways that are incorporated in this drug to, keep that from happening. Again, prolonged, immunosuppression, always a problem with the JAK2 inhibitors. And there's a potential for a prolonged QT interval. So you have to follow the EKG when you're taking care of these patients and make sure that their electrolytes are at normal levels. And some patients develop peripheral edema on this drug. And again, just like weight gain, that's something that you really just don't like. You're going to be taking this drug for a long time. And to have swollen ankles all the time with your beautiful high heels is really not something that you want. Fedratinib also, many benefits that were outlined in the Jakarta 1 and 2 trials with pretty impressive, spleen and TSS effects. But there are side effects to this drug which are rate limiting for the treatment of patients. There's reports of Wernicke's encephalopathy, so that initially this drug was on hold during the clinical trials because of concern about this neurologic complication. It can be reversed with thiamine repletion. So generally, patients who go on this drug, we check their thiamine and we actually support that with supplementation for most patients. There is real GI toxicity. Patients may need to be on an anti-nausea or anti-diarrhea drug chronically while they're on the drug. Again, fatigue and weight gain, just like the other JAK2 inhibitors. There's reports of blood clots on this drug, and so most patients should be on low-dose aspirin. There are reports of pancreatitis on this drug, so not only do you follow the regular things that we follow, like kidney and liver function, but we're also looking for signs of pancreatitis, cytopenias, and if you're a current smoker, it looks like there may be an increase in cardiovascular events if you're on this drug. So it's not a drug for people who are smoking. So the use of the FDA-approved JAK inhibitors, may require the addition of secondary drugs in order to tolerate. And for example, Zofran, which is a good medicine to keep you from having nausea, the retail cost per month is $200. And again, just like everything else, I can't predict what your copay is going to be for that. Some side effects actually require that the dose be decreased of one of the JAK inhibitors, or that you hold the drug. So if you have to hold the drug a lot of times, or you're actually not getting the maximal dose, you may not be getting the maximal benefit. So it's important to think about that when we are treating patients with these drugs. Drugs often need to be started at a lower dose, that they don't tolerate the higher dose of the drug for one reason or another, or they're very elderly with a little bit of renal dysfunction, and you get a little concerned about starting them on, treatment doses that are high that might cause problems in these organs. And because of the potential for side effects, the need for secondary drugs, the needs for EKGs and labs, some patients may require an increased number of visits just to monitor these toxicities and for reassurance. So more time in the car, coming to see the doctor, waiting for me, and wasting your time, when you're not at work or enjoying your friends. Clinical trials are so important in the MPNs, and I was complimenting Laura, who had to leave, who has a wonderful talk on why you should be participating in them. But none of the approved drugs we have fully address patient symptoms, particularly fatigue, and really address the underlying disease. Nothing is replacing allotransplant as a cure for myelofibrosis, for example. Many of the clinical trials are combination treatments, and a combination treatment is going to potentially add to the toxicity of therapy, and certainly is going to add to the financial toxicity of therapy. So if any of these drugs are approved and you're talking about 2 drugs that are $20,000 a month, like what's insurance going to do about this? And what is Medicare going to say about these combinations and their willingness to pay for it? So these combinations are only going to be covered, I think, if they really replace things like allotransplant or show a significant impact on the bone marrow morphology and progression of these disease, because there's going to be pushback, more and more pushback, particularly in the Medicare population, as to what they're going to be willing to pay for. And I'm concerned, as to how that's going to move forward. The only way to improve the outcome of patients really is to get patients to enroll on clinical trials. But there's a lot of resistance, and that's partially because there's a lot of responsibility placed on the patient to participate. You have to come in person, and you may need to have a few bone marrow biopsies. And you may actually, that might be a big problem. And clinical trial eligibility and endpoints are really controversial amongst even the MPN doctors. We haven't come with the FDA to a conclusion of what the right endpoints should be for these clinical trials. So we're not actually measuring something that might be important to you. And this is important for you to understand. When we design these clinical trials, I think there needs to be more consideration of patient outcome, their symptoms, their transfusion burdens, their MD appointment burden, and potential hospitalizations. And it has to be really thought about hard in clinical trials and how we design these and move these forward. I'm just going to briefly say there are integrative medicine approaches to symptoms and toxicities. You can look at this online. Basically, they're very mixed as to whether they improve quality of life and whether whether they're tolerable. At the ASCO guidelines for fatigue and cancer, really the only thing that looks like it's really promising is exercise and cognitive behavioral therapy. We're talking about a small number of trials. But when you look at almost everything else, and here's a list of all the fancy things that people want to try, essentially nothing looks like it has any impact on fatigue. So fatigue is a symptom we just don't have a treatment for. And we're looking for one. And I want to thank my team at Cornell. Luckily, we're all very friendly and like each other a lot. And so this is the group that I work with, and I'm very grateful for them.